Now let us start our discussion on the major nerves of the upper limb. Well, when we talk about major nerves, it is the musculocutaneous nerve, the radial nerve, ulnar nerve, and the median nerve, especially the radial, ulnar, and median nerve here. Now, I want to take first 5 minutes here and just giving you a slight orientation about how these nerves are leaving the axilla and coming into the arm and then having their distal course, and then we'll take them one by one in more detail. So first, I want you to look at the pictures which I'm showing you guys. This image here is showing you the some of the nerves coming from the brachial plexus and also showing the relation with the muscles in the arm and also with the axillary artery. If I enlarge this image for you, what you can see this here is the lateral cord of the brachial plexus, and this here is the medial cord of brachial plexus. If I mark them in the proximal region here, this is the lateral cord, and that is a medial cord of the brachial plexus, and rightly so. You can see in relation with the axillary artery is such that this is lateral to the axillary artery and this one is medial to axillary artery. If you remember, we said how median nerve is formed. Median nerve is formed by the communication of lateral root of median nerve and medial root of median nerve. Now, can you see this lateral cord is giving off this lateral root of median nerve here, this one, and this is a medial root of median nerve which is crossing over the axillary artery and joining here, and that's how the which nerve, median nerve, is being formed. So as you can see, this is the formation of what nerve? This is the formation of the median nerve. See, we are not going to discuss same thing in a schematic diagram, so you better have an orientation understanding here itself. So which tells me that when the median nerve starts, it is actually present lateral to the artery, isn't it? The formation in such a way that the contribution comes from the lateral cord and from the medial cord, but the medial root of median nerve, which is coming from medial cord, is crossing the artery superficially and then joining on the lateral side. So what you'll see that the median nerve starts and it will be seen running lateral to the brachial artery. Obviously, there's a brachial artery after that. So in the initial course, median nerve is lateral to the brachial artery. Then in the middle part, what you'll see, it is crossing the brachial artery and coming toward the medial side. You can see it is, that's how it is. Let me just look at this. That is how the median nerve is coming, and then in the middle part, you can see it is crossing the brachial artery and coming now toward the medial side. And by the time you reach the cubital fossa, look at this. In the cubital fossa, the nerve is now on which side? On the medial side. Remember the content of cubital fossa we said are MBBS. M, the median nerve will come first and then the brachial artery. But this relation is exactly opposite here. So in the beginning, the median nerve was lateral to the brachial artery. In the middle, it crossed the brachial artery. And in the lower part, it is now coming toward the medial side of the brachial artery. The further course, we will discuss that in some time. I just want you to understand the proximal course first. So that's what the median nerve is doing. It is basically related. That's how it is related to the brachial artery. First lateral, then crossing it over, and then comes to the medial side. Ulnar nerve. If you look at ulnar nerve, well, from the medial cord, this major nerve is here, is the ulnar nerve. And obviously, ulnar nerve is simply, it is on the ulnar side only. It is on the medial side of the brachial artery, and that's how it stays through and through. No crossing, nothing. It is coming from the medial cord. So ulnar nerve is the one which is keep running on the medial side of the artery here. And now what you'll see, because the ulnar nerve, we all know it has to go behind the medial epicondyle. So in the in the arm region, there is a intermuscular septum here. Guys, we have a medial intermuscular septum and we have lateral intermuscular septum. So this median nerve will pierce the intermuscular septum and then goes behind the medial epicondyle. You can see that. If you trace this ulnar nerve, it comes down in there, and look at that point here. Look at that point where it is piercing what? It is piercing the medial intermuscular septum, and that's how it is now going backward, and you can see it is going behind what epicondyle? Behind the medial epicondyle. We'll take care of the further course in a while. The third major nerve that you can see in the same image here is the musculocutaneous nerve. Again, musculocutaneous nerve coming from which cord? Only lateral cord. Remember LML. There are three branches from the lateral. So we have now musculocutaneous nerve. Guys, look at this. This muscle is this nerve is musculocutaneous nerve. Let me label it for you here. This is the musculocutaneous nerve. The first thing the musculocutaneous nerve is doing, it is piercing and supplying the muscle that is coracobrachialis. Look at this muscle, coracobrachialis, originating from coracoid process. So you can see it is piercing the coracobrachialis muscle, and after piercing it, it now passes deep to the biceps brachii. This is a cut section of biceps brachii, so it is running deep to the biceps brachii, but superficial to brachialis. This muscle is biceps brachii. This muscle here is brachialis, and the one which was pierced by the nerve is the coracobrachialis. I'm not labeling it. So you can see that the nerve is basically running between the biceps and brachialis. Obviously, we'll supply both of them. And we also discussed this part earlier, that this musculocutaneous nerve, after supplying all these muscles, the biceps and the brachialis, it will continue on the lateral side, is also seen in the roof of the cubital fossa, and continue as the lateral cutaneous nerve of the forearm. And that's why the name is musculocutaneous nerve. It supplies three muscles. One is coracobrachialis, one is biceps, one is brachialis, and then continue its journey as a lateral cutaneous nerve of forearm. So we saw the a little course of the median nerve, ulnar nerve, and how musculocutaneous nerves are there in the nerve that you cannot appreciate in this picture is the ulnar, the radial nerve, because radial nerve is behind. Radial nerve comes from the posterior cord of brachial plexus, which is hidden behind the axillary artery. I can't see it. What we'll do is, let's flip this picture. If we turn this picture, then you will see the back. Now you're seeing the dorsal aspect. Now from the dorsal aspect, I hope you remember these spaces here, the quadrangular space, the upper triangular and lower triangular space. Now look at this, guys. Lower triangular space, along with the profunda brachii vessel, is also giving passage to this radial nerve. The radial nerve here is running in the spiral groove which is present between the lateral head and the medial head of the triceps. This is long head here. This one is long head. This one is a lateral head, and the one which you can see deeper there inside is a medial head of tricep. So it is basically running between the lateral head and the medial head of triceps. And now what you see, the radial nerve, if I enlarge this for you, is going toward the lateral side. Now, ulnar nerve has to go behind the medial epicondyle, from anterior to posterior. Radial nerve is running posteriorly, but ultimately radial nerve has to come in front of the lateral epicondyle. So what radial nerve will do, that once it crosses the spiral groove, it will also pierce the lateral intermuscular septum and then descends downward. Look at that. That is a lateral intermuscular septum. The radial nerve, after crossing the spiral groove, it pierces the lateral intermuscular septum, goes in front and downward, and in front of which epicondyle? Lateral epicondyle. Ulnar nerve, you can see it is behind the medial epicondyle. Radial nerve is ultimately going in front of the lateral epicondyle. So it is very important to understand this initial course, because the rest of thing is more about their innervation, that we can easily understand. So if you got an idea about how exactly these nerves are going to start and supply, so let us start with the first major nerve here, and that is the radial nerve. Let's first talk about the radial nerve, and then we'll go further with the median and ulnar nerve also. See, we got to keep it very simple. We have to filter out the unnecessary information. We just have to focus on the things which are needed to answer the questions effectively. So when you talk about radial nerve, guys, the radial nerve, it comes from the brachial plexus, and the entire brachial plexus contributes to it. C5 to T1. The root value for the radial nerve is C5 to T1. If, let us say, this here is the shaft of the humerus, and let's presume this here is the lateral epicondyle, and this is medial epicondyle. Let me write LE here, that is a lateral epicondyle, and this is a medial epicondyle. Let's presume this groove here is a spiral groove, which is at the back here. So I'm just putting on highlighter here that this is the spiral groove or radial groove. What you just saw in the radial nerve is that the radial nerve, it leaves the axilla through the lower triangular space, and then this radial nerve runs in the spiral groove or radial groove like this toward the lateral side. After that, we saw it pierces the lateral intermuscular septum and is seen running in front of this lateral epicondyle. In front of the lateral epicondyle. Once the radial nerve reaches in front of the lateral epicondyle, now it is going to divide into two branches. Now, one of the continuation of the radial nerve, one of the cutaneous branch of the radial nerve is called as superficial branch of the radial nerve, which we saw is running all the way down here and was also seen in the roof of the anatomical snuff box. Remember, anatomical snuff box roof was having cephalic vein and superficial branch of radial nerve. MBBS, structures of cubital fossa. S, this is that superficial branch of radial nerve which you have here. Whereas the main radial nerve, the one which is going to supply the muscles, has to go backward because it needs to supply the extensor compartment muscle. So what you'll see, the major radial nerve will be seen passing backward by passing between the two lamina of the supinator muscle and then it runs behind the interosseous membrane as posterior interosseous nerve. I'm putting a dotted line because it is running behind the interosseous membrane. So guys, this nerve here is what? This is the superficial branch. This is superficial branch of radial nerve. This on the other side is the posterior interosseous nerve, and how this posterior interosseous nerve reached at that point? By passing between the two heads or the two lamina of the supinator muscle. If you remember, supinator muscle was present in the floor of the cubital fossa. One of the muscle which is forming the floor of the cubital fossa is the supinator muscle only. So that supinator muscle is providing the passage for the posterior interosseous nerve to go at the back and then run behind the interosseous membrane as posterior interosseous nerve. You know, when it comes to the course and the distribution, course and the relation of the radial nerve, this is what you need to remember mainly. That radial nerve from the axilla goes into the radial groove or spiral groove. It pierces the lateral intermuscular septum. It runs in front of the lateral epicondyle. It gives off a superficial branch. It gives off a posterior interosseous nerve, and the posterior interosseous nerve is the one which is running behind the interosseous membrane by passing between the two lamina or the two heads of supinator. Now we also have to see that what major muscles are supplied by this radial nerve in the different region. Again, very precise innervation is probably not needed here. Just for your understanding and to answer the questions, we first need to see that what main muscles are supplied in what region, because what we have to understand that if there is an injury to the radial nerve in that respective portion, what is the presentation the patient will have. Remembering the name of every single muscle supplied by that nerve probably will dilute the process. So as I said, it is very easy. I mean, you already know all the extensor muscles of the forearm. Yes, posterior interosseous nerve will supply every single extensor which is present here. But there is no point in writing all the names in this region. As I said, we don't want to dilute the process. Radial nerve in the axilla. Radial nerve, when it is in the axilla, it supplies the triceps muscle. And to be more precise, it supplies the long head of the triceps here. Long head of the triceps anyways was coming from the scapula only, from the infraglenoid tubercle. So it supplies triceps, long head. When this nerve is running in the spiral groove or in the radial groove, the radial nerve again supplies triceps. It again supplies triceps. Well, what head of tricep it is supplying here? It is supplying the lateral head. Now what you have to understand, one information which I need to add here, which head of the tricep is still left? Medial head. Now that's a speciality, guys. Medial head of tricep is supplied twice. In the axilla also and in the spiral groove also. So it is not only supplying the long head, it is also supplying the medial head of the triceps, which is again supplied in the spiral groove, which tells me that the medial head of the triceps is the largest head of the tricep also. Without looking at the size, just by looking at innervation, you can make out it is the largest head of the tricep. I'm not saying longest, of course, longest is long. Okay. The largest head, the biggest head of the tricep is the medial head, which is supplied twice by the radial nerve, one in the axilla and then in the spiral groove. Yes, here it also supplies the anconeus muscle. Again, I'm not very much bothered about it. Anconeus, you can kind of ignore it for now. Now coming to the very, very important point, that once the nerve pierces the intermuscular septum on the lateral side and comes in front, before it goes in front of lateral epicondyle, please mark my word, guys, before it goes in front of lateral epicondyle, it supplies two important muscles here. One of them is the brachioradialis, and another very, very important muscle here is ECRL, extensor carpi radialis longus. So one straight question which can be asked here is that if the injury is to the radial nerve here at the lateral epicondyle, now what all muscles will be spared? The one which will not be affected? Well, all of these. Triceps, anconeus, brachioradialis, ECRL, these muscles will not be affected if the injury to the radial nerve is here at the lateral epicondyle. Only the muscles after that will be affected. So although brachioradialis and ECRL are the muscles of the back of forearm, but they are not supplied in the back of forearm. They are supplied here only, above the lateral epicondyle. That's very, very important here. And especially I want you guys to highlight this ECRL muscle. You will understand why I'm stressing so much on ECRL. We'll come to that. What is the situation below? The posterior interosseous nerve, this posterior interosseous nerve, let me go with this one first, is supplying all the extensor here. Extensor digitorum, extensor pollicis longus, extensor pollicis brevis, extensor indicis, extensor digiti minimi. No point in writing all the name. You know that all the extensors are supplied. Remaining extensor carpi radialis brevis also. So remaining all extensors are supplied by what? Posterior interosseous nerve. Remaining extensors at the back of forearm. Remaining extensors at the back of forearm. They are all supplied in here. Just one muscle name which I would like to write separately because that will help us fetching the answer to some questions is extensor digitorum. Just write this name separately, extensor digitorum, and do highlight this one as well. So one muscle which I requested to highlight was ECRL, and now I'm asking you to extensor digitorum muscle. You should also highlight this one. We will come to that point. What about superficial branch? Well, guys, obviously superficial branch is the one which is running deep to the brachioradialis muscle here, and then it will appear on this lateral side over the snuff box and is supplying the skin at the back of the hand. Now, how much of the skin is supplied in there? That again is a point of a slight controversy. Let us say this here is the back of the hand. Sorry for this weird diagram. So how much of the back of the hand is supplied by this? Like, few authors says it is 3.5. Few says it is 2.5. Doesn't matter. It vary from person to person. You cannot quote that standard textbook says this and they say, because this is a cutaneous innervation should not be quoted from any textbook. I believe that because it may vary. It may vary between you and me. So in some people it can be 2.5 of the back of the hand. Some people it could be 3.5. So I'll go with the traditional thing that is a 3.5. So let's say if I divide the back of the hand into 3.5 and 1.5 part, and I just leave the distal phalanx part, guys, I'm just drawing this line here so that I can leave the nail bed part or distal phalanx part. Remaining portion, look at the portion, precisely the one which I'm highlighting here, is supplied by this superficial branch of the radial nerve. Is supplied by the superficial branch of the radial nerve. This is what the superficial branch of the radial nerve is supplying. It is supplying the back of the hand, lateral 3.5, okay, except their nail beds. What about the nail beds? If I just talk about the respective nail beds, that this one, half of this, full of this one, full of this one, and full of this thumb also. These nail beds are supplied by the branches of the median nerve, digital branches of the median nerve. And you know why these questions become clinically important? Because they will ask you a question like this. A patient goes to goes for a little surgical procedure in which the nail of the index finger need to be removed. If the nail of the index finger is to be removed, then which nerve we need to anesthetize? Then obviously the nerve that we need to anesthetize is the median nerve. If it is an index finger, if it is thumb, still medial. If it is a middle finger, still it is median nerve only. But yes, if it is the ring finger or the little finger, in that case, then you have to go with two. Like if it is a little finger, then only ulnar nerve is the one which is there. So you have to anesthetize the ulnar nerve to remove the nail of the little finger. But yes, if it is the case of the ring finger, then a very good chance is that half is by the radial, half is by the median nerve and half is by the ulnar nerve. So you might have to anesthetize the branches of both the nerves if you have to remove the nail of this finger here. So that is where all these a little anatomical knowledge will help you fetch the answer to those clinical questions. There's a very recent question only that to remove a nail bed of the index finger, which branches of which nerve are need to be anesthetized, and that is a median nerve. So radial nerve doesn't supply nail bed of any finger at all. So radial nerve can never be an answer for any finger ever. Either it is median nerve or it is ulnar nerve or maybe both. Both in case of which finger? In case of the ring finger. Now, if you understood this much portion of the radial nerve extension, this is good enough to answer like almost all questions, guys. Radial nerve supplies triceps in axilla, radial nerve supplies triceps in the spiral groove, radial nerve supplies ECRL above lateral epicondyle, it supplies extensor digitorum by the posterior introitious nerve, by this posterior introitious nerve. Should highlight these name of the two nerves here, and the superficial branches supplying the skin at the back of the hand in the lateral 3.5 part. Now, what are the possible site of the radial nerve injury, guys? What are the possible site of radial nerve injury? Common site, I would say. The common site of the radial nerve injury could be axilla. There could be injury in the axillary region. So let me say this is case A. Another possible site of radial nerve injury could be in the spiral groove. Let me call it case B. Another common site for the radial nerve injury could be in front of the lateral epicondyle. That is case C. And if there is an injury to the posterior introitious nerve directly, let's say that is case D. The four most possible scenarios for the injury of the radial nerve we talk about, there could be injury where in the axilla, like in crutch palsy. There could be injury in the spiral groove, that can be in case of what? Saturday night palsy. There could be injury in front of lateral epicondyle. Simply, there is a fracture of lateral epicondyle, there are chances of radial nerve injury. And if there is injury like to the head of the radius, this nerve is very, very close to the head of the radius. So like surgical removal of the head of the radius or a fracture of the head of the radius can also lead to the posterior introitious nerve injury. Even if the nerve gets occluded between the two lamina of supinator, something called as supinator syndrome, the nerve can get occluded between the two heads of the supinator. That again can lead to the involvement of which nerve? Posterior introitious nerve. So now we need to see that if a patient comes to with the injury here, here, here or here, what will be the difference in the findings? So let me just start writing this, guys. Case A. Let's start with the case A there. So case A, injury was there, injury in axilla. If the radial nerve is injured in the axilla, and that palsy is called as the crutch palsy. The crutch palsy. Using abnormally long crutches can put excessive pressure in the axilla and can cause crutch palsy. If you use a very long crutch, then that pressure will be exerted into the axilla here, and that can lead to the crutch palsy. That is a compression of the radial nerve in the axilla itself. Now, if the radial nerve is involved in the axilla, that means everything supplied by the radial nerve is gone. It is the injury is in the beginning, in the very much in the beginning part here. If the injury is here, that every muscle is gone. Guys, triceps is gone, all these muscle, everything is gone. So just think of the condition now. If your tricep muscle is completely involved, then obviously your elbow extensor is gone. Tricep and anconeus are the elbow extensor. Your extensors are gone. If your elbow extensors are gone, the elbow will come automatically into the flex position because your biceps and brachialis will bring it to the antagonistic position. So the elbow will come into flex position. All the wrist extensor digitorum, extensor indicis, extensor digitum minimi, all the extensors of the wrist and fingers are gone. So your wrist will be flexed and your fingers will be flexed also. So this is called as a wrist drop, and these fingers folded will be called as a finger drop. And these two different things. This is a wrist drop here, and that's a finger drop here. So now you have an elbow flexed, you have a wrist drop, you have a finger drop, and also there is a sensory loss because superficial branch is also involved. So where the sensory loss will be? On the dorsum of the hand, on the lateral side. So typically the position of the patient might be like this. You have a flexed elbow, you got a flexed wrist, you got a flexed fingers, and you also have a sensory loss at the dorsum of the hand. That is in what case? The case A. Let me discuss the rest of the cases also, then we'll write about them. Now, how it is different from the injury in case B. In case B, if the injury is in the spiral groove, somewhere here, you all know that is called as a Saturday night palsy. Right? If that is a Saturday night palsy, guys, then obviously what muscle is spared? The muscle which is still working or spared is a triceps long head. Now, if the triceps long head and the medial head are working and lateral head is involved, so that tells me that the triceps is partly working. And if triceps is partly working, in that case, the elbow will not be in the flex position, because yeah, you have a tricep power, but yeah, power of the tricep is not to the par. So we have a weakness in elbow extension. So elbow extension weakness is there, and rest of the features are exactly still the same. You still will have wrist drop, we still will have finger drop, we still will have a sensory loss on the dorsum of the hand. Case C, if the injury is at point C, that is at the lateral epicondyle, in that case what will happen? Now this time the tricep is perfectly alright. No issue with the tricep, guys. If the tricep is perfectly alright here, that means there is no issue with the elbow extension. Elbow is perfectly alright. It can do flexion, it can do extension, no issues. But point to be noted here is that brachioradialis muscle, you can ignore it for now, but ECRL, that's the one. ECRL muscle is spared. It is not involved. All other wrist extensor, every other extensor of the back of the forearm is gone. But which one is spared? The ECRL, extensor carpi radialis longus, is spared. That means out of all the muscles which are responsible for the extension of the wrist, only one wrist extensor is still working. And that's why the patient may not have wrist drop. Because one muscle is working, so he may not have a wrist drop here. But will he have a finger drop? Yes. Because which muscle is still gone? Extensor digitorum is still involved. So finger drop will be there. So in this case, in case C, what you see, no issue with the elbow. No problem with that. No wrist drop. Why no wrist drop? I'm saying because ECRL is spared. So the patient may not show the wrist drop to you. But finger drop will definitely be there because extensor digitorum is involved. And you still have the sensory loss at the back of the hand because still superficial branch of radial nerve is involved. And in fourth case, or the case D, if the injury is to the posterior interosseous nerve, now what will happen? Case C and case D are more or less same only, but the one difference will be that in case D, the superficial branch will be spared. Now the cutaneous innervation is spared. So you still have finger drop present, just like case C only. No wrist drop, but finger drop is there. But this time, the sensation on the back of the hand is also intact because that nerve will be spared if the injury is only to posterior interosseous nerve. That's how we'll differentiate between the injuries of the radial nerve at the different level. Let me write that for you. So first we said case A, injury into the axilla, that is crutch palsy. So what happens in crutch palsy is, let me just write down all the points here. First thing, that triceps is involved completely, right? Triceps is involved completely. That lead to what? That lead to the flexed elbow. That lead to the flexed elbow. All wrist extensors are involved. That will lead to the wrist drop. Let's call wrist drop as WD from now. There will be W, there is a wrist drop. Finger extensors are also involved. Extensor digitorum, extensor indicis, extensor digitorum minimi, they are all involved in this case. So there is also which drop? The finger drop is also there. Let's call it FD. Finger drop is also present. And finally, superficial branch is also involved. And that lead to the sensory loss. Sensory loss at the lateral 3.5 of dorsum of hand. Lateral 3.5 dorsum of hand and finger, except the nail beds. I don't have to tell you that, except the nail bed. So I've just written everything for the first case. For the rest of the case, we just have to write the differences. So in crutch palsy, there is flexed elbow, there is a wrist drop, there is a finger drop, and there is the sensory loss at the lateral 3.5 of the dorsum of hand, except the nail beds. Whereas coming to the case B, in the case B, injury is where? In the case B, the injury is in spiral groove. The injury is in the spiral groove, and that is what you call as the Saturday night palsy. I'm sure everyone knows the story behind this Saturday night palsy. Well, some people might not wait for the Saturday, so it could be any night palsy in that case. So Saturday night palsy. And what happens in Saturday night palsy, guys? What is spared? Triceps. Triceps is partly involved. The long head and medial head, some is working and some are gone. So triceps is partly involved. If triceps is partly involved, then there is only weakness in elbow extension. In that case, there is a weakness in elbow extension. And rest of the features are still the same. We got a wrist drop is present, finger drop is present, and we still have the same sensory loss also. So don't have to write it in detail. Wrist drop, finger drop, and sensory loss, exactly like the previous cases there. The only difference is triceps is partly involved here. Case C, the one we marked as case C, is the injury at the level of lateral epicondyle. Injury at the level of lateral epicondyle. Well, how can it be? It can be because of the fracture of lateral epicondyle. So in case of a lateral epicondylar fracture, there are chances of radial nerve injury there. So what changes you will see in there? Now this time there is no involvement of triceps. Triceps is supplied, all the heads are intact, so no issue with the elbow extension. Don't have to write that. What is the main thing to be noted from here is that which muscle? ECRL, extensor carpi radialis longus. ECRL is spared. And if ECRL is spared, there may not be wrist drop. There is no wrist drop. And see, I'm saying there may not be wrist drop because just one muscle is working. So you might have a patient showing you just the weakness of the wrist extension, or he might show you the wrist drop also. But if you ask him to extend the wrist, he might show a mild extension of the wrist. So not necessarily that wrist drop is definitely there. Okay. I mean there are very good chances that there is no wrist drop at all. No wrist drop means like the patient is always able to hold the wrist in this position. But because this just one muscle we are talking about, so the patient might show you the wrist drop in this case also. But when you ask him to extend the wrist, he can extend the wrist to an extent because of one muscle is working. In the previous case, not a single muscle was left which can do the extension of the wrist. So that is not possible in the Saturday night palsy. But in the lateral epicondylar injury or in case C, the possibility of wrist extension is there. So the patient, we usually say it is no wrist drop. But yeah, he might come to you with a wrist drop because only one muscle is there. But when you ask him to do the extension, he can do a weak extension at the wrist. Extensor of the fingers, extensor digitorum, and all these muscles, extensor digitorum is still involved. Extensor digitorum, extensor indicis, all these are involved. So finger drop is there. So no wrist drop, but finger drop is there in this case. And we still have superficial branch involvement. So there is sensory loss is still present. Sensory loss is still present. And finally, coming to the case D. In case D, what will happen? In case D, it is the posterior interosseous nerve injury. So we are basically talking about the injury to posterior interosseous nerve, and there could be various regions for posterior interosseous nerve injury, like it could be a supinator syndrome, as we said. It could be a supinator syndrome. It can be the fracture of radial head. It can also be during the surgical excision. The surgical excision of the radial head. Surgical excision of the radial head can also lead to the injury to posterior interosseous nerve. So whatever the reason may be, the supinator syndrome it is, fracture of the head of the radius, or during the surgery of the or surgical excision of the radial head, if the posterior interosseous nerve is involved, now the scenario is still ECRL is spared, Extensor carpadilis longus is spared. So again, no wrist drop. Still same scenario, finger drop is present. And this time the main thing is, let me use a different color to mark that which nerve is also spared? The superficial branch is spared. The superficial branch is spared, and that will lead to what? So there is no sensory loss at the back of the hand. There is no sensory loss. So no wrist drop, no sensory loss, only finger drop will be seen in this case D. That is about the radial nerve, the major point about the radial nerve and the different level radial nerve injury and what you expect the patient to come up with the presentation.